Okay, welcome to this session. This is Designing Healthcare Environments. Mark, yeah. As a previous high school dropout and turned healthcare provider, I am thrilled that design is on the agenda now. So I want to present the first of our three presenters. This one's entitled Humanizing the Hospital Front Entrance Experience Through Co-Design. And we have Caylee Raber, Director of Health Design Lab, Emily Carr, Michele, Trask, who's the Senior Clinical Planner, St. Paul's Redevelopment at Providence Healthcare. Welcome.
So thank you very much for having us. We're really excited to be here and to share this piece of work with you. Like Liz says, I'm Caylee. I'm the director of the Health Design Lab at Emily Carr.
And I'm Michele, and in full disclosure, I no longer work for St. Paul's. I'm actually the Director of Operations at the BC Cancer Centre, which is now going to be embarking on a whole other design and renovation project, so I'll be able to use some of these skills that I learned with my buddy Caylee.
Yeah, so we're working on new projects over there as well now. So today we're going to share with you how the Health Design Lab used human-centered design methodologies to gather and generate insights from the community to inform how we might create an entrance experience for patients and visitors at the new St. Paul's Hospital that will be empathetic, human-centered, and supportive. And so this project resulted in a series of recommendations for St. Paul's and their redevelopment team, and hopefully will be used by their future architectural team to help inform the design of that new space. So this is, really sort of exciting work that's happening really nicely sort of in advance of the new build and this sort of intensive design phase. Okay.
So just a few quick words about the new St. Paul's. The new St. Paul's is essentially a brand new hospital build, health campus build that is meant to innovate, renovate, recreate, and invigorate healthcare for British Columbians. It has a whole new philosophy on care and is meant to totally shift the way that patients experience care, families experience care, the community experiences the building and the services itself. It's meant to fully integrate with the community in many levels. And essentially, design becomes a very important piece of this because the way that the physical infrastructure is developed and structured can have a huge influence on the way that people behave within the walls of the building. So having the right philosophy and tools in terms of design right at the outset was a really key and important element of this huge project. So just some context. Essentially, this is the piece of land that the new St. Paul's will be built on. For those of you who are a little bit familiar with Vancouver, anyone who knows where Science World is, and kind of near the Science World, there's that big old building. There aren't very many old buildings in Vancouver, so the big stone old building that used to be the train station. So right beside that, there's a huge parking lot that's full of cars at the moment, and this is actually where the new hospital will be. And the actual physical space of that new hospital is influenced by many factors. So, of course, there are engineering reports around what kind of dirt and earth there is and what kind of building can be supported in that space. So there are some outside limitations in terms of what the building could potentially look like, as well as, where the city plans future roadways and things like that. Anything from view cones. The city doesn't like it when buildings obstruct the view of the mountains because that's, so quintessential to who we are as Vancouver. So there's some pieces like that that are limit what can actually be accomplished in terms of a physical building on that space. This is a mock-up, so we don't know if this is exactly what the buildings will look like, but it just demonstrates the concept of having more of a campus-like feel. So there's space in between, there is opportunity for parks and life, and a little more infiltration and permeability with the community and the space there. So that's kind of some of the ideas behind it. So quickly, the timeline. So the project has now been approved. You'll see on this arrow sort of the different steps. And at the point in time when this project was done in conjunction with Emily Carr, we were sort of at the just kind of past the business plan place. So we had completed the business plan, it had been submitted, and that took a relatively long period of time with the changes in government and whatnot. But the project with Emily Carr started before the business plan was completed, and sort of we were able to include some of the elements in that business plan, fortunately.
So our collaboration for this project, we titled The First Five. It was really focused on what should those first 5 minutes be like when somebody enters this building, this campus. What might be their first 5 needs, and what might be people's sort of first 5 actions within that space, and how can we sort of consider those? So my team, which involved myself and 3 student research assistants from Emily Carr, began by asking ourselves questions like, what will be the emotional state of people as they enter the facility, and how can this be considered in the design of the spaces and services that are offered? In the Health Design Lab, we focus on the use of human-centered design methods to improve the design of health products, services, and experiences. We believe that participatory co-design processes, which involve people with lived experience, will lead to better design of healthcare facilities, better experiences for patients and the staff and the people who work in those spaces. So our project involved sort of 4 key steps. The first was a series of observations at existing sites, including existing hospitals and healthcare facilities, but also we were looking at airports and shopping malls and other sorts of public spaces. Then we designed a series of tools specifically for this project to elicit information from people with lived experience. We led 3 co-design workshops that were open to the community, and then we sort of synthesized everything that we had learned. So, like I said, my team started by doing observations of people's movements, interactions, and use of spaces. So these were some of the facilities that we spent time in, and we spent an hour or 2 sitting there, not being healthcare practitioners ourselves, really sitting there from a less biased perspective, looking at how different spaces were informing people's behaviors, and in some cases where spaces were presenting challenges for people. Utilizing sort of the insights from our observations, our team started to develop specific activities for the workshop. In the Health Design Lab, we're really focused on how can we help to sort of draw out information that's sort of locked in people's minds that maybe is not sitting at the surface. So rather than just sort of pulling up an empty piece of chart paper and asking people, what do you want? How can we use sort of make tools to draw out insights from people? And so we started to sort of develop these activities, and we hosted 3 co-design workshops with people from the community, and the Patient Voices Network helped us in trying to get a group of participants that would reflect the sort of multicultural, multi-generational community that will be accessing St. Paul's. We started the workshops with sort of a quick icebreaker, asking people to pick an image off of the wall. These were photos, some of hospital spaces, but some of sort of home spaces or other spaces, asking what's something that you would be really excited to see in a hospital, or something you would really not want to see. And key themes sort of immediately emerged from that, people wanting sort of natural wood, not liking sort of the glossy, shiny kinds of spaces. Our next activity was called a persona activity, and here we acknowledged that although we tried to get a diverse group of participants to attend, they still didn't adequately represent the full range of people who would be accessing services at St. Paul's. And so we created these 6 personas to ensure that while we were keeping our own lived experiences in mind, we were also trying to think about the experiences of other people who might be unlike ourselves. And so we created these personas and gave people different scenarios for people who might be coming to the hospital, and we asked people to imagine, what do you think these people could be thinking, feeling, and needing upon entry into these spaces? And just as one example, one of the sort of personas we presented was Edha, and we said that she was arriving here to visit her father with her children. English is their second language, and they have sort of strong cultural practices. And so we started to develop ideas with participants for how we could address some of those needs. And then the last activity was about a floor mapping activity, so giving people different icons and images to start to actually map out what that space could look like without having, being influenced by any sort of architectural drawings at that time. So really starting from scratch. A couple key insights that came out was this notion of not everybody likes to sit and wait, and how could we encourage more active waiting and sort of wandering. So this idea of a wandering loop came up. Another sort of key insight, especially from our observations when we went to a lot of sites, is a lot of sites build these massive front desks and then they sit empty. And that really, in some ways, I think actually detracts by providing this sort of unfulfilled promise. So how can we, not build these grand reception desks, but actually have sort of pop-up desks when there is staff to sort of fill them? So all of this was sort of put into report for the St. Paul's team, and I'll let Michele sort of speak to how that was helpful for their team.
Thank you, Caylee. So this was fantastic for a lot of reasons. We did have multiple engagement strategies on the project, and many times what we did is, for example, we would have people come to meetings at the hospital itself, and as many of you may know, St. Paul's is a very old hospital. It has many deficiencies in terms of wayfinding and other physical infrastructure type things. And so, of course, people would come, struggle to find parking and be, not very happy with having to find a room called the Villa in which there are no signs to indicate how to get there. And there are 3 different elevators involved in getting there. And so they would arrive and give us a list of all the things that they didn't like about the current building, which is great. But of course, you can imagine that if we've got a list of all the things that we don't like about the current building, we could very easily fix those with a whole lot of other ideas that might be worse. And the activity with Caylee and the students that we hired through her school essentially helped us sort of get away from the particulars of what it was in terms of like a laundry list of like, okay, I want comfortable seating, I want light, I want wayfinding that's intuitive. But all of these things mean such different things to different people. So when we actually had an opportunity to go outside of the hospital setting and engage in this kind of an activity, it really helped sort of peel back the layers and find out what are those sort of fundamental things that are living behind those desires and requests that people were bringing forward. So that was hugely helpful. The other piece that I think is really worth mentioning is that I mentioned that we had a number of engagement strategies. So there were a number of town halls that were held in conjunction with the City of Vancouver, and they were well attended. There were multiple times of day, different days of the week, sort of trying to get a lot of people to attend. We networked with the Patient Voices Network. We established a Patient and Family Advisory Committee. And then when we did each of the different steps that were along the trajectory of that arrow, for example, one of the steps is indicative design, where you actually kind of test out different floor plans and designs. We invited patient and family partners to engage in that with us. But there were some key groups missing. For example, there were no young people that came to any of these town halls or any of these, signed up to be patient advisors. There was a couple of young people that actually came to the sessions at the hospital, but I mean, truly, like, we're building this building for them, for the future. So through our connection with doing this project, we were able to access a whole demographic that previously we hadn't had access to. So,
thank you.
Thank you.
I tried to check the time on your phone, but it's not.
Any questions? I have a question about...
I can talk loud. I had a question about, I'm Carol Wilson from Fraser Health, and I had a question about how you, when you said you went out and looked at other places, we were at a conference in the fall where Calgary Health, or Calgary, South Calgary, whatever it's called, South Calgary? South Health Campus, where they did a very similar thing, including actually put a labyrinth on the floor in the waiting room, or in an area where people could walk. Speaking of a walking thing. But I also was interested in a project that I had done at Providence around the navigation of the building. And there is, by the way, in case you need it, there is a tool to assess how to navigate the healthcare system from a health literacy perspective. So if you want that, I'm happy to tell you where that is. So my question is around when we're looking at the design and we're looking at space, I heard you say usability. are you also considering the usability from a time and motion from a staff perspective as well? Because I noticed that when they redesigned, say, Richmond Hospital, for those of you who are from Vancouver Coastal, the design of the main lobby ended up being terribly difficult for staff to navigate because it was a rocky floor that you had to push patients across. So it's just an interesting kind of look when you're trying to balance between usability of patients versus usability of staff.
Yeah, I think it's always important when we're designing that we do need to consider all of the people who will be using a space, and staff definitely are a huge piece of that. In this case, our objective was primarily to make sure that we had the patient and family voice, because we weren't getting that as much through some of the user group meetings that were happening. But definitely everybody who's using that space needs to be considered.
There were some, not associated with this particular activity, but in the project in general, there were some simulation activities that we did where, you know, we had this mother with 3 kids bring in her stroller and try and, you know, maneuver around the bed and do some things like that. So we did embark on quite a few of those, and there were some amazing learnings that you think about it after and you're like, oh, but...
Thank you. We've only got a few more minutes, so I saw a hand. Okay.
I was going to ask Richard Merchant from Fraser Health as well, and so we were rebuilding the Columbian, they're going to rebuild Surrey, they're doing VGH, they're doing St. Paul's, they're going to rebuild Duncan. I mean, we're terribly fortunate, aren't we? We've got so much money to spend on these things. I hope you're sharing this information, because for God's sake, it's not like we're not all going through the same exercise, I would imagine anyway. Your demographic is a tiny bit different from ours, but I mean, it's a great idea using artists, let's say, or designers to design stuff. I hope it's online or somewhere available for others to use.
Yeah. There is some great sharing happening just on that note. Have you heard the toilet story? I mean, you're from Fraser Health. You must know the toilet story.
Fraser Health is not a toilet.
No. So when they did that rebuild, part of that rebuild over in Surrey, they had a toilet exercise. So basically they had a bunch of toilets at different heights. They had a bunch of patients and staff come and try these toilets at different heights. And they did all kinds of work on these toilets. And we got this information at the new St. Paul's. So we'll be using the toilet information from Surrey, because after they opened, I mean, they had complaints like everyone would and does, but they had no complaints about toilets. So...
Thank you. Enough toilet talk. One more question. Someone's got the mic.
Hi, yeah, here.
Hi.
Just a question on design. Modern design can become outdated quite quickly. So has there been much thought into making designs that are at least somewhat modular, so that maybe they're still familiar to patients that are coming back and forth over the years, but refreshed in terms of the layout?
I mean, I think that is definitely a focus of design for health right now. In terms of the scope of work that we were looking at, we weren't actually coming up with specific designs or for like furniture or specific rooms. We were really looking at design from a human-centered perspective. So how do we understand what the user's needs are? And so we're still in that sort of need identification space and the role of design in that space.
Thank you. I'm sorry we're out of time for questions, but I know Caylee and Michele will be around afterwards. Thank you. So next up we have collaborative development of a primary care network in Burnaby, British Columbia, and we have Eunice Cho, who's the Director of Burnaby Health Services and Hospital Fraser Health, Charlene Lui, Board Chair, Burnaby Division of Family Practice. Welcome.
Okay, thank you for having us here. As I've been introduced, I'm Dr. Charlene Lui. I'm a family doctor and the board chair for the Burnaby Division of Family Practice. And I've got Eunice Cho, who's one of our leadership teams, and she's the operational director of Burnaby Health Services. So we have nothing to disclose. And I want to take you through a bit of our journey, how we came to the development of a primary care network, or a PCN, in Burnaby. And first of all, why? Why did we do it? Well, some history or some context. Primary care was in crisis, is in crisis, but it was in crisis even more before. And in Burnaby, we had a particular problem because the family doctors who work in community but also provided longitudinal care for patients in hospital, they actually left the hospital when the hospitalist program came into Burnaby, and it for a number of reasons, but the result of it was that family physicians working in community were very siloed. Not only were they siloed, but actually the health authority resources and community groups were also in their own silos, and the silos causes loss of connection, and for patients that is a problem. We would like to have seamless and easy and quality access for our patients, particularly the vulnerable patients, and that's why we got on this journey. So as a result, one of the results of the silos in a physician world is physician burnout. Physicians were really focused on trying to take care of their patients in their practices with their nose to the grindstone, working as hard as they could, and realizing that that patients were falling through the cracks. There were some gaps in services. There were probably some services out there that they actually knew nothing about because they're not connected to a lot of the community resources. And so our goal was to build connection and look at the big picture to make it easier for patients to access our services. So the first step was the division of family practice from a physician point of view anyways. The division of family practice came together to build engagement, to build connectedness among the physician community so that the physicians could be supported in the care of their patients and also begin to learn who their colleague down the street is so that they could share their care and help each other to provide better care for their patients. And so a big part of our work was engaging the physicians and building relationship with the ultimate goal of better patient care. And that takes time, as that's one of my take-home messages, is engagement and building relationship is key, and it takes time. Then we also had to build relationship with our health authority partners as we began on this journey, because we knew that the health authority provided a lot of services that we needed to be better integrated, and we couldn't work together unless we were in relationship and understood each other's worlds. That's a second key message, is take the time to understand each other's worlds. The health authority in their hierarchy kind of structure is very different from the physician community in our structure, because in a physician world, the physicians are autonomous, independent business owners who can really structure their business the way that works well for them and their patients without really worrying about the guy down the street. And so we are trying to build a world where there's better connectedness. And for the division of family practice, as we get into collaboratively building a PCN, the different structures, the hierarchy versus the autonomous 160 different business owners is very different. The hierarchy, they can make a decision here and say, okay, everyone do it, and everyone does it. In our world, in the physician world, we can't make our physicians do anything. We can encourage and engage and resource and cajole and even beg, but we can't make them do anything. And so that difference in structure was challenging and something that we really needed to work on. And we also worked on our roles of engagement, which was helpful for us in a leadership role to understand where we're each coming from, build trust, underline transparency, and realize again that we're all working for the same goal. We're all working towards better patient care, and so that really, spending the time to do that really helped us. Then we had engagement in the physician to physician, we had engagement within the leadership team, and we needed to build engagement from physician to health authority. And that was a challenge too, because there was a lot of distrust there. And so we actually used a conferencing model to get in the room together. And the health authority, God bless them, they put on their bulletproof vests and they went in the room and they said, give us feedback. We welcome feedback. And the physicians did. They gave them lots of feedback, and the health authority came out with at least 200 stickies of things that that were their feedback. And we got in the room together again and built an outcomes map. And the outcomes map with the ultimate quadruple aim and better patient care at the goal line, but aligning all of these 200 projects to get us down the road towards the quadruple aim. And what we realized from that process, we knew the system was complex, but realized it was really complex. And that if we try to attack one project here, it has an effect on 20 projects over there. And so we realized, okay, we need to actually have a broad vision, and which is why we built our blueprint. So our blueprint is, you won't be able to read it probably, but it is just our vision for going forward as we transform the primary care system for the next 10, 20 years. And we felt that if we had a blueprint, a shared blueprint that we worked on and developed together, that we would be able to do our project work and do these little things with an ultimate goal, and we wouldn't get off track. So our blueprint, of course, has the patient in the center, working on enhancing the patient medical home, which is the physician office, webbing those physician offices, patient medical homes together so that they can share care and physicians don't have to do 100% of the work 100% of the time. They can share with their colleagues and they can share with team members. So we built the primary and community care team that can be better embedded in the care of the patient so that it's more seamless. And also we recognized there's lots of other players that provide important care for our patients. There's community NGOs, there's the city, there's school board, parks board, all kinds of other stakeholders that come to the that help improve wellness in a community. And so we actually did engagement events with all of those stakeholders, everyone we could think of, all of those I just mentioned, plus ambulance and firefighters and senior advocates and new immigrant centers and all kinds of people. And we built a system where everybody has the patient wellness and seamless and access and quality care at their center. So Eunice is going to talk about where we are now.
So recognizing that you can't probably read all of these, and that's not the purpose of it, but this is our blueprint in its entirety. And really, when it comes around to looking at some of the results, as Charlene described, we had this situation where the physicians were working in silos, that we wanted to start really embedding the work and creating these partnership opportunities together. So we completed that conference model. We listened to a lot of the challenges that physicians were having around how they provided care for their patients. And so we started the work around embedding and supporting the care provision for patients with our primary and community care nurses and our primary and community care team. So that work started in September of 2017. And now we have 59 physicians of 150 physicians who are actually engaged in this team-based model. And so this translates for us in terms of patients, nearly 1,700 patients who are our most vulnerable and frail population who are receiving services in this particular model with an integrated team. And so the changes have been very positive for the residents of Burnaby, and that's something that we're continuing to strive for. And the staff and the physicians are continuing to be excited and moving towards this positive change. So a few of the lessons that we've learned, as Charlene said, it's been hard to go for, we've been one of the Wave 1 communities that have been going first, and it's been hard to go first. And much of the work has been unknown, and really looking at defining some of the parameters and trying to get everyone on the same page and working together has been difficult. Preserving and protecting having the trust relationship and continuing to build on trust has been a huge and important factor in moving forward together. The ministry has also taken a significant part in our partnership together, and so embedding and having those discussions with them has been key in terms of moving forward and managing expectations. We've been dreaming big, yet there's limitations, and so how do we do that? So it's been an art in terms of working through that. We still and continue with some of the struggles around our organizational structures and the different mandates that drive us forward. And so it sometimes causes tensions and challenges along the way. And so it hinders some of our decision making, our ability to look at governance models. And so it requires a lot of energy from us as a team to really go in and on together and combat these challenges. And so in terms of next steps, we've got a few things that we have outlined at this point is really around the development and implementation of our detailed plans for our teams moving forward for providers, nurses, allied health within our new centers for healthier communities and incubators that really support attachment of new patients to primary care providers. And then the other component is really establishing new processes for the new staff that will be coming on board. We have over 40 new nursing and allied health professionals, as well as 17 GPs and NP providers that will be joining our teams in primary care networks in the future. And so for us, really, as we move forward, we really recognize that the system transformation is really complex and it requires a lot of trust and collaboration and engagement, and those are the critical components that we've moved forward with. And so, any questions?
Thank you. Okay, any questions? Pop your hand up and we'll get the microphone to you.
Hi, I'm Chris from Clinical Informatics in the community with VCH. We're embarking on our own journey to do the primary care networks with the divisions. Just a question more about the technology side or the communication. Given that doctors, independent practitioners have their own systems that they have to, how are you guys working together to sort of address the gaps in technology? Because you're using different systems, of course, and are we doing faxes? Are we emailing each other? How are...
That's a hard question. So super crucial, the communication among physician offices and as well as among the team. We are still working through it, but we do have some things that we are working on with the health authority, for example, and their IT unit, and also with Doctors of BC. And we are hoping to be one of the innovation hubs for IT with the ministry's work. So, but that's, the province is working on this work as well. But yeah, really crucial. At the moment, we're still faxing for normal referrals, but within the team, they're actually communicating by text and phone calls. So that, because the team within the practices actually is quite closely allied with the work that is happening in the physician office as well.
And those nursing and allied health members right now are writing in the EMR of the physician.
Thank you. That was very good. My name is Ryan Douglas. I'm with Vancouver Coastal Health, and I was just curious, when you're talking about your team, the nurses and the allied health clinicians, where do you envision them being located?
Me?
And how do they work together? With the physicians?
What I would say is I think we're currently in a lot of discussions around where where team members may sit, and I think that the reality is it may differ depending on the connection and the closeness with each of those providers. Right now, within Fraser Health, we have a centralized team model where we have an office and all of our community staff. That's their kind of hub space, and then they go out and disperse and do the work. And so whether that, we have within our service plan Centers for Healthier Communities where there may be an opportunity for hubs of team-based staff there. There may be opportunities within physician offices where they have capacity and room for some of our team members to be a part of their local offices. It may be in a central, we need to look at it based on the factors around what makes the most sense in terms of being able to connect and get the work done and provide that. So, and of course, we have 3 primary care networks right now within Burnaby that we're continuing to build, and so we may have different hubs available inside of those PCNs.
Yeah, and it depends on what kind of allied health provider it is also, whether it will be an allied health provider that actually works within one PCN in one geographic area because there's a higher need, or whether it's someone who actually is shared across PCNs. So, but we're going to do a mixed model.
So I'm just curious, Heather Straight from BC Nurses Union, at what point have you or do you engage the nurses and the allied health in the vision that you have? Was it created and then they come in, or were they part of creating the vision?
So I think we've had lots of discussion, and I think the change management component around supporting staff through change has been a really critical part of the work that we've had to do. This type of change is really difficult for staff, and so we within our Burnaby Health Service area, we do have a change team that is made up of staff members who are helping to support us in the work that's happening. And so they've actually done some journey mapping with us and really been able to tell us what are some of the stuff that they're going through that is challenging. And so it is taking all of the stakeholder feedback and bringing that together. There's because there's been right now so much discussion around what's kind of within scope with the Ministry of Health, that it's kind of like there's a fine balance in how we engage all of the stakeholders, which includes, of course, our staff members. So as now we develop the work, I would say more involvement in terms of staff being a part of that, as well as patients, families, providers. We need to engage all of those stakeholders together.
So our final presentation, simulation-based mock-up evaluation of a universal operating room. And we have David Borkenhagen and Sheila Fleck. Shelly, sorry, it's my old eyes. Thank you.
Thank you. Good morning, everyone. Thank you for joining David and I this morning. We realized we're the only thing between you and lunch, so we hope to keep you engaged. I am a Director of Surgical Services at Vancouver Acute, and David is a human factor specialist from the Workplace of the 21st Century, an organization based out of Calgary. First of all, what we would like to say is we would really like to recognize all the efforts and the collaboration that we received as we went through this process with members of our project team. The leads were Jonas Schultz, David, myself, Emily Rose, Brendan Gibbons, Hannah Regill, Ellison Muniak, and John Filer, and of course, the many surgical program members that participated in the mock exercises that David's going to tell you about. We have no involvement and we have nothing to disclose. So a little bit of context on what the project is and who we are at Vancouver General. So Vancouver General, as everyone knows, is a quaternary tertiary hospital based here in British Columbia. We do also have a community component that sometimes people forget about. So we do offer services to the spectrum of patients. We are currently in the process. Our project is a 3-phased project to develop 28 universal operating rooms and 2 interventional or hybrid rooms. We are currently in phase 1 of our approved project, which is the build of 16 operating rooms on the 3rd floor, which is just above our current 2nd floor operating rooms at VGH. While we do not have the luxury to build a brand new building like our friends at St. Paul's or the Royal Columbian and some of the other facilities across the Lower Mainland currently are at right now, we do have an open floor plan. So we do, that is a bit of a luxury in that we do have an open floor in which we can design. The intention is to, through our operating room renovation, is to meet our current demand for surgical activity within an expanded capacity. Right now, we have 20 operating rooms within VGH. We do provide the spectrum of surgical services at Vancouver General. We provide, obviously, the high-end, some of the real specialty work that's only done at our site. For example, transplants, multi-trauma, high-end spine surgery, high-end neurosurgery, really some very acute oncology surgery, and then again, we provide a mix of other surgery that other organizations also provide. The Universal ORs, our project, one of the things out of the gate that we really died on the hill on, if you will, is around the concept of universality. We are building 16 rooms that are 650 square feet. They are square, and we are building them so it can be any case, any room. No service is going to own a room. We are not building anything for any specific service. They are truly universal. Designing ORs, certainly I think when we design anything within a healthcare facility, it is complex, but certainly designing physical environments, and in this case operating rooms, is a complex process, obviously. It's critical for staff as well as patients who are going to be coming through those rooms to feel supported and to have the environment support and facilitate optimum patient care. Given the diverse set of surgical procedures that I just told you that we do, we as a project team, OR project team, felt it was really important for us to embed the expertise of human factor specialists into our design process, because what they can do is help us to iteratively evaluate, verify, and validate the universal OR design that we all came out of the gate thinking that we wanted and we knew that we needed. So really they brought that objective third-party perspective, and as David will tell you in a few minutes when he starts telling his story, is using evidence to support the decisions that we make. We felt that conducting simulation-based mock-up evaluations as part of our design process would enhance patient safety, staff efficiency, user experience. It would yield efficiencies, potentially financial returns, but most importantly, it would end up in best design that would carry us through for the next 50 years, because it'll probably be that long before we can get back in and renovate the ORs again. Our aim was to conduct mock-up evaluations as a part of the design process, and really the scope of the project included assessing our mock-up exercises and really providing recommendations to inform our decisions that we made as we went through each of these mock-up exercises. What we focused on was evaluating the space for task completion, access to objects, placement of objects, and visibility within the room, given the complexity and the many, many providers that are in an operating room at any given time. So at this time, I'm going to turn it over to David, and he'll walk you through our mock-up process.
David. Yeah, so as Shelly was saying, we did these mock-up evaluations of the universal operating room. So these are simulated scenarios, and they were enacted with healthcare staff, so nursing staff, surgeons, anesthesiologists, residents. We had them all participate in this mock-up evaluation, and we gave enough sort of timing in the project scope to incorporate the results from this evaluation into the design, prior to these design sheets being signed off. And our evaluation followed this framework, which is published by the Health Quality Council of Alberta, and it lists out the steps necessary to conduct these mock-up evaluations. So this document is available for free on the HQCA website. So the mock-up occurred in the basement of the Vancouver General Hospital. So this is what it looked like from the outside. It was built out of this steel frame with drywalls around the side for the walls and the ceiling. And inside this space, you can see it looks a lot like a clinical environment. So we had a lot of elements in there to simulate, to replicate what a real operating room space looked like, and that includes things like power outlets and code calls and sterile gloves. These were actually images that were placed on the wall, fixed to their appropriate locations. We actually also had OR booms, monitors, and lights that were mocked up using cardboard and plywood. But each of these elements had the same maneuverability as you'd find in the real world. And we also had case-dependent equipment. So this includes things like anesthesia, the anesthetic workstation, the anesthetic machine, surgical table, a bear hugger, a ligature, carts like case carts, procedure carts, supplies, drapes, gowns, surgical instruments. They were all in this space, and that again is just to have that level of fidelity that can that will allow the participants to enact the same sort of clinical workflows that you'd see in a real-world environment. So as I was saying, the scenarios were enacted by nursing staff, surgeons, anesthesiologists, and residents, and we had anywhere from 1 to 6 healthcare staff in the room at the same time. And we had 4 cameras that were positioned in the top corners of the room. So this was used for part of our analysis. And they were in all 4 corners so we could get sort of the right angle on all the behaviors that were occurring in the space. And we ended up conducting 3 different scenarios in this space. So they were selected based on their relative frequency, how frequently they occur in the real world, and then also that they represent sort of different complexities, so they're going to sort of challenge the room in different ways. So the 3 that we selected were the laparoscopic thank you, and the hysterectomy and a thyroidectomy. And one of the scenarios involved a collection of a specimen, and another involved a bed rotation. So the 2 types of data that we collected, one was debriefing data. So this was obtained from participants and observers following the enactments, and this helped us to assess potential challenges of the room design and just gathered sort of general feedback. The video recordings were used to conduct 2 types of analysis. One is a link analysis, which is the one that you see in the bottom left there. So this shows the participant movements, and it's color-coded based on the clinical role. So whether you're a surgeon or a nurse or part of the anesthetic team. And then this gives us sort of a visual representation of areas of high volume or congestion or underutilization. And then we also conducted an analysis of observed behaviors such as congestions and bumps, which is that graph on the right. So this allows us to sort of assess how workflow is interacting with these, what we consider to be adverse behaviors that we want to discourage through the design of the environment. And then the results, so this is just sort of a high level, these are the link analysis from the 3 different scenarios. So from this, we're able to identify the utilization of the room. We can see overall there's a pretty good utilization, except for in that top left corner, which is along the core wall. So we're already sort of can develop some recommendations from these results. And then we also looked at equipment usage, specifically the equipment that sort of interacts with the head of the surgical bed. And we were able to identify several pinch points, which restricted the flow through the space. Then there's the congestion map in the middle there, which demonstrated that there was a high cluster of congestions in that bottom left corner, which is near the door leading to the sterile core. And then the bumps maps sort of indicate sort of an overall normal distribution of bumps, and which is good, especially in the area around the sterile setup. We saw very few bumps and also very few instances of bumps between sterile and non-sterile items, which can be an instance of contamination. So the results from the data that I was showing you, it sort of informed these 29 evidence-based recommendations which were presented to the design team. So these recommendations addressed relocation of doors, booms, OR lights, the wall-mounted gases, the workstation reconfigurations, and also equipment procurement criterion. And the vast majority of these recommendations were incorporated into the design. And then we also had the opportunity to retest these recommendations, which I'll get to in a moment. But here's an example of the iteration 1 of a recommendation, how we communicate these recommendations visually through the use of these graphics and photos. So the recommendation was to move the door in the pass-through window to the right. So you can see in iteration 1, it's in a particular location. In iteration 2, we rebuilt the space with that recommendation, and we can compare. You can see the door has been moved along the core wall. So one really great thing about this study is that we actually were able to verify whether these design changes actually had the effect on behaviors that we intended that they had, predicted that they had. So this was accomplished through rebuilding the space, so actually incorporating these recommendations, reconstructing the mock-up again, and then repeating one of the scenarios and conducting the video analysis again to compare the two sets of data. So these are just the flow diagrams, the flow maps from the two iterations. And the data from iteration 2 suggests that the second design, this revised design, did actually lead to better utilization. So we consider workflow to be more evenly distributed across the room. We also received feedback that there was better space, more space for boom storage, and that the relocation of the door and the pass-through worked well in reference to the surgical carts and case carts that get stored in that area. And then with regards to bumps and congestions, we saw significant decreases in congestions and bumps, and as well as readjustments. So again, this data did show that this revised design did actually lead to improved behavioral outcomes. And also in relation to the equipment placement, we saw that the equipment was being placed more further away from the head of the surgical bed, which was identified as a pinch point. So the debrief data also corroborated what we see here in the visualization, that there was more space at the head of the bed.
Some of the lessons learned for our project was that really simulation-based mock-up evaluations do offer an effective approach for engaging frontline users and creating evidence-based decision-making that really impacted our final design. By enacting simulation scenarios, we effectively identified the opportunities to impact our design. I think it's human nature for everyone to come at things from their own perspective, but what really the human factors analysis and our mock-up analysis evaluations enabled us to do is really objectively look at where we could make things better. Next step, so we talked in some of the two previous conversations about how we share our findings, and we absolutely have shared our findings. We have toured a number of the Lower Mainland facilities through our mock-up space, as David showed you in the picture. What we built in our basement was really a 650 square foot operating room that matches exactly what's going to be in our design. We've toured Royal Columbia, Richmond, Lionsgate, St. Paul's. We had Kamloops come down a couple weeks ago, and Burnaby Hospital. We're working with them to bring them in as well. So certainly we are more than open to share all of our findings, what worked for us, what didn't work for us, and why we landed where we landed. Really, the recommendations generated through this series of our exercise, we believe can be considered for other folks as well in their design. And really, it's our recommendation that everyone go through a process like this. It really does take out the personal, anecdotal, really siloed approach to what people bring to the table, and they are able to see design from a higher level, 40,000 feet level, if you will, and it's really more comprehensive and holistic. Thank you.
Thank you. Any questions for Shelly and David?
Sorry, I might have missed this at the start. How common is that type of analysis? Are you guys kind of creating a new way of doing this, or is this common in industry?
So I'll maybe answer from our project. So what we did in the project, we actually ran 18 different mock exercises. So we did these 3 that David walked you through, but then what we really tried to do, because we're building for universality, and as I said, knowing all the services that we provide at Vancouver General, we put just a range of all the services in there. Our last mock, our 18th mock, was our high-end spine work, and honestly, I think we had every piece of equipment we own in the OR in that room at the time, and what we found was it was still, it was a pretty compressed room, clearly, but we were still all able to move around, and we were able to make where we have the booms and all our power, data, gas, suction, and everything worked, so it worked. What we did in our design was after every 3rd mock, we sat back and we reevaluated the findings from 3 exercises. What we found early on, you find something in the 1st mock and then you change it, and then you find something in the 2nd mock, and it was hard to keep track of what you did and what the impact was, so we made the decision after our first 3 that, we're just going to measure after every 3rd mock, see what needs to be changed, to make the change, and then go into the next 3. And we tried to put, really rigor and some decision-making around the process that way.
Yeah, I would say sort of anecdotally, it's not as common as I think it should be. I'm out of Calgary, and only a couple projects, I've been only involved in a couple projects that take this approach to space design. But we did some work at Southwest Campus that looked at this, with ambulances that looked at this, but considering the amount of construction that's happening there with new healthcare spaces, I think it should be more common.
Hi, have you ever seen this applied in primary care space?
Yeah, so I think that's what they did at the South Health Campus. I wasn't involved in that project, but they were looking at patient care units, and then also we did the evaluation of medication rooms, so more so used by pharmacists and healthcare staff.
Like anything in a team-based doctor's office? Have you ever seen it applied in community that way?
I have not. I've seen literature that references that type of work, but I haven't done a project like that myself. Yeah.
Hi. So fabulous work. I'm curious, when you're doing your mock-ups, did you include students? Because they're often in those spaces.
We did. We absolutely did. So what we did when we did the mocks, we basically, anyone who works in the perioperative space was in there. So we had housekeepers, we had PAs, we had AAs, we actually had, as you see in the mocks, we had real people come down. So we had, when we were running, I think it was the ENT service, they brought 2 residents with them. Because what we really tried to do is simulate who's in the room, and then all the movement that you saw in David's diagrams, what we found is, if someone had to go and walk to the physician desk to get something, and then they had to walk to the nurse's desk to get something, well, where could you put it so that you weren't going back and forth all over the place? So we used all of those findings to really land on our design. Even from a patient perspective, I know we have patients and family members in the room today. What we did, because our mock space was in the basement and it was cold, and we met at like 6:15 in the morning to 7:30 in the morning, it wasn't the greatest time for non-surgical people to meet, but that's when we could run these exercises before everyone went to their day. So what we had was some of our staff act as patients. So, and it was really interesting because what our staff people were able to say is, I'm the patient being worked around, and people are talking around me like I'm not there. And really just being respectful of, it's a bit daunting to come into this big cold room and you've got a gazillion people around you and all the lights and technology. So we really came at it from a patient perspective as well. Like, what does what does that look like for a patient coming in? We wheeled the bed in, we really simulated everything that we actually do. We didn't make things up, we didn't, we really tried to make it as authentic as possible, obviously within a simulated space. But our findings, certainly I'm the clinical project director for the water renewal project, and we are very happy where we've landed with our design. Yes, I think we're going to get into the space and go, sort of miss that. But I think just given all the rigor and all the work, and we've had our whole surgical program engaged, we are feeling good about the design we landed up with, for sure.
Thank you. I think we only have time for one more question.
Okay. Hi. Very inspiring. One question. Because things are changing so fast, and you say you're building it for 50 years, how are you incorporating like future developments and new technology, because the mock-ups are based on existing technologies?
Yeah, that's a great question. Absolutely. That's one of the things we all are very much aware of, is we know what we know today. We've really been leaning on our surgical colleagues and nursing colleagues and folks for what do you see coming down the pike really for us, and what should we be aware of. But what we've really tried to do in the room is make sure that within our current environments, just the equipment that comes in and how the patient is positioned and where the table is and what's coming in and out, that we've built in lots of services. So, we've really optimized our booms, what's the services coming into the booms. We're optimizing the services that are going into the walls. Working in an old environment where we are now, every time we have to bring in, a new technology, we're behind the walls trying to get some new IT lines run. So we are really overbuilding, if you will, in those areas, so that, down the road, if we do have to pull more data or we do have to pull more power, it's already behind the walls, and it's just a case of going behind and connecting them. So it is a challenge for sure, but really, again, that's where really the universality component came in. We were really keeping it as generic as possible. Right now, within our current footprint, if any of you have worked at VGH or you're aware of VGH ORs, we have 20 rooms. They're as small as 300 square feet in rectangles. Some of them, they're different shapes, they're different sizes. We're limited in who can go where. So, cardiac can only go into 5 and 7. Trauma can only go into, 1 and 18. And so we've got back up of cases, right? So with the universality, it's like who's ever up next, you can go into the next room. We've cohorted the services into the room so that we could build the sterile cores around it, right? So whatever services need will be close to their room, but really no one's going to own a room. So what we've said to the services is, you as general surgery may always work in this pod of 4 ORs, but if someone else is in one of those rooms today, you can go somewhere else and you'll be fine. We'll get your equipment or whatever you need. So we aren't going to have that limitation. It's really
Thank you. I'm sorry, we're out of time. I'm sure our presenters will be happy to answer any questions. Big hand for all our presenters. Thank you very much.